So now I think we're going to invite the panel for discussion, and that includes Anita as well, and Adam, and the surgical team. Let's see. Libby. Libby was there too, but she's not in here. Maybe Laura, you want to go as an image representative? Anyway. And we probably should start with Adam. There was a question, Adam, about your virtual reality. What specific software are you using in some of the pretty pictures you showed?
Yeah, certainly. We've actually used a mix over the years. And I'll say that through the 3D printing program, we have access to some brilliant engineers who can use mimics and materialize to do some of these segmentations. Most of the images I was showing you are from Elucis, which does allow you to do the segmentation in virtual reality. But like I said, there's a lot of great options. 3D Slicer, that open source software I mentioned, can do all this with high fidelity. So it's really just the headset is your main cost from that perspective.
Do you think, is it virtual? Yeah, sometimes we wonder, do we do a 3D model, a printed model, or do we actually just play with the virtual reality? Actually, Victor also uses those models for planning. Yeah. Have you been playing with the virtual reality itself? Because I imagine there are some advantages of one versus the other.
Right.
Well, I have to say, for some really complex cases, virtual reality is really cool and nice, and helps you get a perspective that at times in just a printed model doesn't give you. But I think having both is extremely useful for really complex cases.
Yeah, I think the added value of the VR is that you can section it in any possible plane and do it repeatedly depending on what your particular interest is. Whereas the value of a physical model in your hand really gives you perspective and scale. I think can be maybe a different experience to have something the size of the room in front of your face, but then recognize that it's something smaller than your hand, and certainly for the surgeons, it's important to have that scale.
Yeah, that makes sense. Wonderful. I was wondering, when you look at the Ross procedure, especially also Abihu, you should be up there too. With all the, some of these patients that come for Ross don't come from home. They are very, very sick. They're on drips. They have failed other therapies. However, my understanding is the Ross procedure is an STS category 2. Isn't that right?
Yeah.
And aortic valve replacement is a 5. So, or something, 4 or 5. No? It's not 4, something like that?
Honestly, I don't remember, but it's not. It's interesting because when you really look at the Ross, in most centers, there's just a few people that do the Ross. And I think the outcomes of the Ross are so good, the mortality is so low. But I would argue that it's not because for example, it's like the double switch. The double switch is not a category 5 anymore. I believe it's category 3. But there's only few people that do it. So those few people that do it very well and has a very low mortality, but it doesn't mean that if you put it in everybody's hands, it's going to be the same outcome. So I think there's, I'm not sure.
It is a complex surgery.
It is a very complex.
I mean,
and not
idea.
Everybody, for me to say it's a low category, like a Ross is if he's a 2, honestly, I don't remember. But not everybody does a Ross, and we know that it tends to be more experienced people, the same as Nakairos and Rastelli. They tend to be the more senior people, and not everybody does them. So be what it is. I mean, but certainly a Ross procedure requires experience, especially if you want to, if it's going to have good outcomes, long-term outcomes of a valve that functions for a long time.
And in some of the surgical series that show how the Ross is so good long-term compared to replacement, one question, and I haven't looked at the data deeply, but is, sometimes we go and say, okay, the patient can't probably won't serve. The Ross is a long procedure and a complex surgery, so we need a quick procedure because the patient has bad function. The patient is on drips in the ICU, super sick, and so goes for a replacement. And then, of course, maybe won't live that long because they have all these risk factors that they were a bad ventricle to begin with. Is that all considered in these series? And do you know, or does anybody
But,
know?
you know, the reality is if you have, for example, if you have a newborn that is extremely sick in the ICU, and you have to do an aortic valve replacement on a newborn, we know that the Ross outcomes on a newborn are not the same outcomes as a child. There's a significant mortality and morbidity associated with a Ross in a sick neonate. So you have to keep that in mind. At times, I would argue maybe, one of the issues you have is you don't have mechanical valves to put in there, and you may or may not have a homograph small enough to utilize.
Right.
So those are some of the realities that we have to deal with. But in a really, really sick kid that you just want to do a quick operation, I would argue just do a homograph replacement, which I certainly done in my career, of a very sick neonate and get him through it.
Right.
And then you can worry about doing a Ross at a later time,
Right.
one step at a time.
Makes sense. There is a question probably for Mario on when would you rather do an Osaki procedure or Victor too, instead of a Ross procedure, if ever?
Well, I think the Osaki procedure has his peak a few years ago, and that's when I think probably 5-6 years ago we were trying to establish Osaki and do Osaki, but the reality after the Boston paper, when the Osaki outcomes were not that great, I think we abandoned to do the Osaki in the patients. So that's the answer. Now, it's always have a tool to work with the pericardium and stuff like that. So I rather, in that consideration, use the height of the cusp using the calipers and maybe use a bicuspidization with the pericardium. That will be the situation. Now, if you can do a Ross, I think you should do a Ross. And I think with the PTFE conduit, that's basically makes put everybody in the same situation, because for many years in Latin America and other places, there's no homograph.
Right.
And they used to have a fresh homograph that they put on a refrigerator with antibiotics and stuff like that. Or the conduit with pericardium that very few people can be able to do it. And the Hancock, to put a Hancock on a Ross is a pain. It's so painful. And the Contegra is so easy to sew at the first time, but once you go back in those patients, the Contegra is a painful reoperation. So at the end, I think when people in other places around the world start using the PTFE conduit, there are gonna be more Ross procedures because they have a choice to put a conduit. That's I think it's gonna put everybody in the equal position.
That's great. In terms of the cross-sectional imaging, we love to get the functional data for the flows on the MRI, but the resolution and the clarity of some of the images on CT is so fantastic. Do you think that we'll be able to have that kind of functional data from a CT down the road?
That's a great question. It's the focus of actually there are multiple people working on this.
Yeah.
The concept of trying to understand if there's a way to infer flow dynamics from the passage of contrast. Sure. Thank you. So there's so it's a great question. Multiple people are working on it. The technology is not quite there yet.
Okay.
It would be so nice to do one. It's so attractive to be able to potentially do one quick test where it doesn't matter if you're claustrophobic. It'll be over in 5 minutes. You just go and get your test and have all the data spit out. But I think the reality is, I'm not sure how promising the early returns on understanding flow to the extent that we can understand it with the MR truly are. So I think for the time being and for the foreseeable future, I think MRI is really going to be the more reliable technology to understand hemodynamics. And that being said, and I would love Adam to comment here too. That being said, there is a lot of focus, including focus here at our institution, on accelerating acquisition techniques so that children and people don't have to stay in there so long, and to also like be a bit more aggressive about spatial and temporal resolution, so we get like better quality data that we can really hang our hat on and be like, nope, the QPQS is definitely this. We need to definitely do this next or whatever. So I don't know. I think MRI still has some potential development.
Yes, thank you. Thank you. All right. I don't know if there are any other questions for anybody, but I think we're going into the time, so we're going to have to wrap this up. And thank you, everyone. If anybody has questions beyond this, feel free to email us. We'll be happy to respond. And I believe that the presentation has been recorded and will be available through the Congenital Heart Academy, and we're very, very grateful for their support. Victor, you want to say a few words closing things up?
Yeah, I mean, I want to thank everybody who logged in. We really enjoy participating in this yearly morphology course. I want to thank everybody, the participants who came. Bob from far away, thanks for doing this. Diane, Bill, thanks for participating and making this a reality for us. And I hope everybody's enjoying it. We look forward to doing something like this again next year. And anything that, you have any questions, please reach out. We're happy to answer. And thanks everybody for participating.
And thank you also for the administrative support, for Drew Burkhardt, Katie Scullin, and also Sarah Harrison for their support making all this happen. So thank you, everyone.